Hello, I'm Dr. Ahmed Abdelal, and today we're going to speak about neurogenic language disorders. Neurogenic means it refers to disorders that are caused by some kind of brain damage. It has to do with neurological. So we're going to speak about brain damage, particularly acquired brain damage. And the focus is on aphasia. But as we speak about aphasia, we are going to speak about what causes aphasia, which the different kinds of strokes, and the features of aphasia. And also, we are going to speak about related disorders, related neurogenic disorders, including right hemisphere damage, traumatic brain injury, and also dementia. And the effect of all of this on speech. I'm going to start with the discussion of the related neurogenic disorders to get them out of the way, and then we focus the rest of the discussion on aphasia and its speech characteristics. So generally, the brain is very fragile, and the consistency of it is like toothpaste. The different kinds of events can damage brain structures in different ways. And one is atherosclerosis, and that is the accumulation of debris inside of blood vessels, especially arteries, accumulation of fat and plaque that is made out of fat, and accumulations of carbon and fibrin and different things that kind of over time they build up around the walls of the artery and the wall of the artery and kind of narrow it down. Eventually, it will cause a restricted area that could cause a lot of problems. So, when atherosclerosis builds up inside of the walls of an artery, you can see there will be pieces that are kind of protruding out, jutting out, and that is a random structures. So that a piece like this, for example, is now on the way of a narrow path. Because generally the wall of the artery now the walls are kind of constricted. That means that the pressure of the blood is increased in this area particularly. So like a hose, when you put your thumb on the hose, the water is going to shoot farther away and it will have greater pressure. That means that if there's an even area an area that's protruding like this, it is just a matter of time before it gets dislodged and before it flows freely into the higher structures of the blood vessel. So this area that is jutting out and hanging out of the wall, that piece of plaque, is called a thrombus, and that is where we just call it thrombus as long as it continues to hang there and it is waiting to be dislodged. So once it gets dislodged, it only has one way because the blood is flowing up. It is going to, and as you go upward, for example, as you could see, the blood vessels become narrower and narrower, gradual, like the branches of a tree. So that little piece of plaque, the thrombus, when it gets dislodged, it gets kind of becomes loose and it flows. Now we call it an embolus, and it flows and it goes up to smaller and smaller blood vessels that are larger than it, but then it reaches one blood vessel that is narrower and it just gets shoved into it, and that blood vessel gets shut down. And that is when you shut down a blood vessel like this, all the area that it is feeding, so to begin the process of cell death. We call this, and when the tissue actually dies, we call it an infarction or an infarct. And then just know that when cells die inside of the brain, they do not regenerate. They do not. We cannot get them back. They just leave a dark area, and then through the process of neurogenesis, the brain, in two areas in particular, and the areas that control learning and memory, there is selective neurogenesis in the sense that some neurons are born and they go around and they kind of implant themselves on the pathways surrounding the damaged area, and this is how the person could get some functioning. But it all depends on timing, of course. If the person is saved within hours, then the damage can be reversed to a great extent. So just again, remember that a thrombus is still attached, is a piece of plaque that is still attached to the wall, and when it gets dislodged and torn off, it becomes an embolus. So you have the names, for example, thrombotic strokes are caused by an embolism that flows and clots and blocks the blood vessel. Also, there are some blood clots that maybe someone has a surgery on the foot or somewhere in the body, and there's a blood clot forming. It finds its way to the brain, and it's going to produce the same effect. So we call these kinds of strokes occlusive strokes. Occlusion is the blockage of something. So occlusive strokes are caused by atherosclerosis consequences and blood clots. And then we have brain hemorrhage. That is when a blood vessel just erupts and it is torn and the blood flows out of it. And most cases are caused by aneurysms that I'm going to speak about later. Traumatic brain injury, that is just car accidents, bullet wounds, any kind of injury that can affect, can damage the brain in random ways, depending on the impact and so on. And then there are tumors in the brain, malignant or benign. And when a tumor develops, it pushes, it grows, and it means it displaces structures are all around it. And that is going to cause loss of function, gradual loss of function, depending on how fast that tumor grows and how big it grows and what areas it grows in. For example, if it grows in the frontal cortex, in the front here, that's going to affect decision making. It will affect vision. It will affect judgment. All the functions basically of the frontal lobe will be affected by that. If it occurs in the temporal lobe, it's going to affect language comprehension and all. So it depends on the function of the area, the nature of the tumor, and how big, where it is, and how fast it grows. Also we have progressive neurological disease, like dementia, for example, and other neurological disease that causes shrinkage or death of brain cells or death of the axons that come out of neurons, so that will disrupt signal flowing through the brain. So in terms of stroke, stroke is an event. It's involves a blood vessel, something wrong happening to that blood vessel inside the brain. So if it's inside the brain, we call it stroke. And it causes the stroke again, as I explained, it can be occlusive stroke or hemorrhagic stroke. It leads to edema, which is a swelling of brain tissue. This is not swelling. This is an infarction. This is an area of dead cell neurons. But around it, if you look carefully, there will be a reddish area around the dead area, and that is this is where it has inflammation and swelling. And then swelling is a reaction of the immune system because it wants to engorge, to enlarge blood vessels and the immune system channels so it can bring in supplies to repair and to clean up the debris and the damage, the debris that's resulting the damage. So there's edema, and there's an infarction or infarct, which is area of dead neurons, because once you disrupt the oxygen, then that means, the blood supply is going to deprive the neurons in this area from the oxygen and glucose and other nutrients that are essential to its survival. And then there's, in terms of spontaneous recovery after stroke, what happens is that down in the areas here, basically in the areas of the temporal lobe, deep inside of it, there's one area in the basal ganglia, and there's another area around in the hippocampus, which has to do with memory. Both of them have to do with memory and learning and motivation and so on. So these are areas that are the only two areas that are known to give birth to new neurons in terms of neurogenesis. So these neurons will go and kind of survey the area of damage around it and try to salvage any information from a dying neuron, and then they implant themselves along the pathways. And this happens within about 12 days, to 2 weeks of the injury. And this is part of what is known as spontaneous recovery. So spontaneous recovery refers to the brain's ability to heal itself and to repair itself, to isolate the damaged area and to kind of try to salvage as much as possible by the neurons getting information from the dying ones. So, but spontaneous recovery can go from weeks to almost like 6 months or even more. It involves reorganization of pathways. That is part of. So if you have a circuit and one piece of the circuit or one member of the circuit just is shut out, then you have other members inside of the circuit trying to kind of reconnect and compensate for that. In any case, even though spontaneous recovery can make a difference in the life of the patient in terms of communication, and depending on the severity, of course, when treatment is initiated early as possible, days, basically from the beginning from having the stroke, that is going to maximize the spontaneous recovery, and it will maximize the functioning that the patient can recover, and also it will kind of provide guidance and to the reorganization of these pathways in a way that will facilitate the functioning of that patient. In terms of brain injury, again, it depends on where it hits. If it hits in the front or parietal lobe or temporal or occipital, it depends on where, because every area is specialized in a particular set of functions. So in terms of the physical damage, it causes traumatic brain injuries cause contusions, which are brain bruises, lacerations, which mean tearing of structures and vessels. Remember that the neuron is has a body, has dendrites, and it has an axon. These axons can be quite long. So a lot of these events lead to severing of these axons or overstretching them or choking them, a lot of things. But when that axon is damaged inside of the brain, it does not heal back. It just is a matter of a couple of weeks and it dies totally, and that's it. So there are also hematomas. These are little pockets of blood that accumulate in particular areas of the brain, and when they accumulate in that area, they of course displace a lot of the structures and neurons and squish them and push them away from their area. And remember, the brain is like the consistency of toothpaste. So that means that you are causing shearing of these axons and tearing and severing of connections and causing a lot of damage, depending again on the extent and the size of the hematomas. So, sorry. Also there are intracranial hematomas, and which means that I'm going to explain here. Here's the cranium, which is the bone, and underneath the cranium there are three major layers of protective tissue that surround the brain structures. And these are together include the dura mater, and then the meningeal layer, or the kind of meningeal membrane, and then beneath is the pia mater. So these three layers together kind of, they go from the hardest to the softest view, from the top. So there is epidural hematoma that separates the first layer of these meningeal layers from the skull, and then the blood just pools here and keeps pushing all these structures away, and that all the functions of this area are going to be damaged. So at least temporarily, until something happens to relieve that pressure. That causes intracranial or intercranial pressure. And in some cases, see that blue line, that is the three layers of the meninges. In some cases, the hemorrhage causes the hematomas to be below the dura, which means we call this subdural hematoma. And that is similar. It keeps pushing, and as the blood pools, it keeps pushing away all these soft tissues of the brain. And you see how that is curving the whole area here, and it is causing the entire brain to be changed, because the pressure is going to radiate to different, deeper areas below and to the different sizes. Here, if there's a hematoma here, for example, that's the pressure will be radiating, in different areas. So now every area is going to exert pressure, and you look at the size of the brain, it has lost its symmetry. It has lost a lot of the functionality. And the solution for this is, when the patient goes to the emergency room, they immediately drill a hole inside of the skull, and they put a tube and they drain that blood out. That's an immediate relief, so that they go then after and they repair the blood vessel. So the effect again of this depends on where the hematoma occurs, how big it is, how big the large vessel is, and basically how fast the patient gets the help. So if it hits in the right hemisphere versus the left hemisphere, the symptoms will be quite different, and we'll discuss that in detail in a few minutes. In terms of intervention, there are many tests, many diagnostic instruments, and so on, and especially the assessments to test cognitive functions. These, however, you cannot administer to every patient, and there are a lot of patients who do not speak, for example, English, or who are bilingual, for example, and they might not be as fluent in English as they are in their native language. And in the meantime, you don't have enough testing instruments to assess the performance of these bilingual speakers. So it is always kind of a struggle because again, there are so many minorities, and it is not in order to develop an assessment tool, you have to have enough patients, for example, and it's in the end it's a marketing thing. But anyways, the clinicians find ways around that, and they design their own methods. So let's now speak about the related disorders, for example, including dementia, RHD, and RHD particularly. Dementia is an age-related neurocognitive decline, and it affects the basically most of the brain is damaged, but some areas are damaged before others. And in some cases, it is pathological if that brain deterioration occurs earlier, like say in the 50s or 60s or 70s, that becomes what we know as Alzheimer's disease. And it has a genetic component as well. So dementia comes in many sorts, many types. One of these types is Alzheimer's disease. Alzheimer's disease cases make up about 70% of dementia cases. And sometimes it used to be called senile dementia. So it is progressive, and it involves deterioration and shrinkage of brain structures because of the buildup of plaque inside and outside the neuron. And that plaque eventually kills the body of the neuron and causes tangles of these axons, and eventually just cutting these axons and choking them so they cannot communicate. And they have shrinkage, widespread shrinkage. So you can look now on the right side, that is severe dementia or severe Alzheimer's. And on the left side, this is a healthy brain. So all of this, of course, this anatomical changes will translate into cognitive abnormalities, and then these cognitive abnormalities will translate into behavioral changes that you see in the individual, affecting cognition and language and behavior and so on. So the main problems that patients with Alzheimer's experience include working memory problems in the frontal cortex here. Many areas in the frontal lobe are dedicated to working memory skills, and orientation. For example, knowing who you are, where you are, what day it is, what month, what year, what country you live in, who are your family members, and so on. Basic facts of life. Reasoning and judgment. All simply because the frontal lobe is the first one to be hit by dementia or by Alzheimer's, and it gradually keeps losing skill and functioning. Right hemisphere disorder is caused by a right hemisphere stroke. So the right hemisphere, in terms of motor functions, controls the left side of the body for the most part. So your left eye here, movement and acuity and so on, is controlled by the right hemisphere. And the opposite is true. The right hemisphere like for example, if there's damage in the right hemisphere, you can immediately tell when you look at the person if they have, their left arm is paralyzed, the left leg is weak, the side of the face is kind of loose. All of this would mean that the stroke is in the right brain, right hemisphere of the brain. And this is the corpus callosum that connects the right hemisphere and the left hemisphere and enables them to communicate together. So the right hemisphere itself is primarily dedicated to emotional processing. It processes the tone of someone's voice, the tone of your voice, so that you can when you speak, you can put the right tone of your voice with your emotions to match, so that what you are saying linguistically matches your emotional kind of mood, and it also matches the appropriate intonation or tone of excitement or sadness, or basically the whole range of emotions that you can demonstrate with your voice. And also is concerned with the processing of things in a holistic manner, like listening to a story. This is the area that gives you, this whole story is about this. The wisdom or the lesson from this story is that. The theme of this story. So you process things as a whole. You look at a picture, you see it as a one thing, not like little pixels, scattered. Our conversational processing, our context, all are processed by the right hemisphere. The left hemisphere is dedicated to the minimal pieces, to the analysis of words, comprehension of words and sentences on the sentence level, and the grammar and the language fundamentals, sounds and word formation are all fundamental language skills that are mediated or are the function of the left hemisphere. So whenever we say aphasia, we only refer to damage in the left hemisphere, okay? Because aphasia is a language impairment that affects the fundamental areas of speech. So the right hemisphere, again, has its own symptoms. We do not call the damage in the right hemisphere, we do not call it aphasia. We just call it right hemisphere syndrome or right hemisphere damage. One of the characteristics of right hemisphere damage is vision cuts in the left eye. So the person, for example, wouldn't see from the left side. If you ask them to kind of draw a clock, they draw half a circle. Or if you give them a clock that is a circle and say put the numbers, they go 1, 2, 3, 4, 5, 6, and they kind of stop there. Make a flower. They go like making the right side of the flower, and the left side is totally just. They think it is there, but they cannot see it. So that's called visual neglect, and it can affect the whole eye or the peripheral vision of the eye in different ways. Also, damage is gonna affect the strength, muscular strength in the whole left side, including face, arm, shoulder, leg. In terms of language and cognitive functioning, the right hemisphere damage affects a person's ability to tell a story. They cannot focus, they cannot stay on topic, they forget details, they just put like a whole bunch of disorganized details together, and you have no idea what you can get out of that story. You keep asking question after question in order to understand the kind of what they're trying to say. There's lack of coherence. And also in conversation, they do not follow the rules of conversation. They might just frequently get out of topic. They tell things that they are not supposed to tell. They cannot read your facial emotions. They cannot read your tone of voice. They wouldn't understand like sarcasm or jokes or and things like that. So they have difficulty also comprehending someone's narrative, like a story that you are telling or a conversation that's going on. They struggle to process the meaning of that in a whole, or to read between the lines, if you will. Now, we are going to speak now about stroke and about aphasia throughout the rest of this lecture. So in terms of stroke, I explained that the major cause is cerebrovascular event that causes deprivation, like of nutrition, for example, deprives a particular area in the brain of the nutrients that come through the bloodstream. The brain doesn't store its own nutrients. It doesn't store its own food. So it depends on the blood supply. And if the blood supply is interrupted for just a few minutes, that could cause damage by interrupting the functions of the areas that that is deprived. So we have again the cerebrovascular event can be a hemorrhage, or it can be an occlusion or blockage of a blood vessel. So the occlusive stroke kind can be caused by a blood clot or by an embolus that was a thrombus that was dislodged and that flows through the bloodstream and blocks a blood vessel. So in any case, the blood vessel is blocked, and the areas that the rest of the blood vessel provides or supplies with nutrition, that whole area starts to die. Then we have hemorrhagic strokes. It's caused by an eruption of a blood vessel. That eruption can be, for example, because of a thin wall, like an abnormally thin wall of the blood, the artery. Arteries carry the blood to the rest of the body, from the heart to the rest of the body. They have that higher level of pressure, and they have a special, they are particularly thick, and they have thick walls. And when you have your blood pressure measured, the greater number, whether that's 120 or 115, that greater number is arterial pressure. And then the other number, the smaller number, if that is 60 or 65 or 80, that is venous pressure from the veins that bring the blood back to the heart without having to contract and without having to experience as much pressure. So in any case, that eruption mostly involves the artery because it is experiencing greater pressure. And as you inflate it more with blood, it becomes like a balloon. As you keep blowing air into it, the walls become thinner and thinner and thinner. If you keep blowing, it's just going to explode. So there are some people who have abnormally high blood pressure that can extend some blood vessels beyond their ability, and that could cause an eruption. There are some people who have abnormally thinner, particular areas of certain blood vessels are just thinner than they should be, and this could be exposed. In some cases, these thinner walls could, with the increased pressure, could balloon out, and they can cause what is known as an aneurysm. So that aneurysm is a little weak area of the wall of an artery that balloons out because of the pressure, and it stays like that. And it continues to grow, and it continues to grow until it reaches a size like a balloon that you keep blowing air into until it cannot resist the pressure, and it's a matter of time before it explodes. So these aneurysms the person is born with these, and they keep growing with the person, and they, until at some point, if they are not discovered, they can explode. So if they are removed before that, the person will avoid a lot. Of course, they can avoid the damage. So that is hemorrhagic stroke, and the consequences of that is, of course, that blood has a lot of toxic materials that is toxic to brain tissue, and in the meantime, when it starts to pool, causing epidural or subdural hematomas, that push and distort and shove the brain down and down through the brain stem, it could very quickly cause death. So in terms of the hemorrhagic, it deprives different areas of the brain from of nutrition, and that is going to cause, if it is prolonged, it can cause permanent damage. So the language abnormalities that result from strokes that occur in the left hemisphere, we know that as aphasia. So aphasia is a left hemisphere disorder. It is caused by strokes for the most part. They can also be caused by brain injuries of different things that can destroy areas of the left hemisphere, like a bullet wound, into some of like Broca's area or some of these areas, or car accident and so on. But the primary cause is strokes. Generally, all of these are characterized. There are many kinds of aphasia, but generally, some general characteristics include an effect on the ability to name something. You show a picture or you show something and say, "Tell me what is this?" And will the person be able to name that thing, or name it something else, or not name it at all, or name it and so on. Fluency problems. Is the person able to use the motor kind of structures to produce speech, regardless if that speech is intelligible or not? We call it, fluent speech or not, like motorically fluent, regardless of the content. The ability to comprehend the ability to comprehend speech, whether you hear it or read it, the ability to repeat sentences and words, the ability to produce a grammatical language. All of these areas are affected in various ways, depending on the type of the aphasia. So now let's sample some of these aphasia, the major aphasias, and we will look at the effects on these areas. One of the earliest, actually the first forms of aphasia discovered was Broca's aphasia. Broca was a neurologist and obviously a surgeon, and he worked with patients as well on different things. And over time, from the 1800s, 1860, and when the patients died, he would take their brains and examine them. And he noticed that a lot of his patients who had difficulty with grammar, when he examined their brains after they died, he looked and found that this particular area was the one that is damaged. So he identified this area as the area for grammatical processing and for motor speech production. So, and that has been very well confirmed, and we know today that is true. So we call this Broca's area. And when there is damage to Broca's area and the pathways that go to it and from it, then that causes Broca's aphasia. Broca's area only exists in the left hemisphere. There's another area we'll speak about here, Wernicke's area. It only exists in the left hemisphere as well. So anyways, when there's damage to Broca's area, the person will have Broca's aphasia, and that leads to non-fluent speech. Like the person will be kind of pausing and kind of struggling to find words. Awkward verbal expression, kind of slow, kind of thinking and trying to find ways to get words out. Short phrases and sentences, and there is a grammatism. It means that the grammatical words are taken out. For example, the grammatical words are prepositions and words that connect sentences together or connect words together, like this: between, in, out, the. So the person, in other words, limits his or her language to nouns and adverbs and adjectives. So instead of saying, I want to go to the store to buy bread, they say, store, buy bread. And they leave out all these grammatical words. This is why we call it agrammatism, means lack of grammar or abnormal grammar. They have difficulty, generally they are able to comprehend sentences and speech. However, if you kind of say a sentence that's complicated linguistically, they will start to struggle, like this. The girl ate the fish that the man caught yesterday. So that is like more, who ate the fish, who caught the fish. They would have difficulty understanding that. But they can understand simple sentence forms, direct sentence forms. In terms of Wernicke's aphasia, Wernicke's area is an area here that is in the posterior superior temporal lobe. So this is the temporal lobe here, and posterior and superior temporal gyrus here. That area is next to the auditory cortex. So this area is responsible for recognizing speech, for assembling sounds into words, and for working with the other areas here to get the meanings of words together and integrate, and then send that to Broca's area. So this area is also extends a little bit into the temporal, the parietal lobe also. So, but it is located here, and two pathways pass out of it to Broca's area here, and to another area, motor area here, for planning speech, and then two other pathways, a path beneath goes down and goes also to the Broca's area. So it is very well connected with Broca's area, so that you have comprehension connected with expression. The pathway that connects the dorsal pathway that connects Wernicke's area with Broca's area, this is called the arcuate fasciculus. Arc means arch. Arcuate means the arched pathway. Fasciculus means pathway. So that pathway is important. We are going to speak about it when we speak about a different kind of aphasia. So Broca's area, damage to it or to the pathways leading to or from it, is going to cause Broca's aphasia. Damage to Wernicke's area or the area, the pathways leading to or from it, that is going to cause Wernicke's aphasia. Wernicke's aphasia, the person is not aware that there is a problem. When that person talks, they make all kinds of errors. They can say something that is not a word, but they continue speaking, called fluent, but there's no content. So there is a video here. Sorry, the link is not showing, but just look for videos, links, and or even just go to YouTube and say Wernicke's aphasia, say Broca's aphasia, and you will find a lot of patients, and you will be able to see them in action. So the person will have difficulty comprehending what someone says. And they cannot even comprehend their own speech. They just talk and they think they are making sense when they are making no sense at all. But their motor skills are totally intact and they can produce sounds and so on. They make a lot of verbal paraphasias. For example, they name something a different name. That verbal paraphasia, it means like say bottle, they might say jug. Glasses, they might say eye covers or goggles. So they name, verbal means they name, give something a different name. Neologisms means they make totally nonsense words, or called jargon sometimes. And they have difficulty with repetition. You ask them to repeat something, they cannot repeat it back to you. When the arcuate fasciculus that connects Wernicke's area and Broca's area, when that pathway is damaged, that pathway sends the information from Wernicke's to Broca's. And it is also a dual pathway. The Broca's also sends information back to Wernicke's, so they communicate. When you disrupt that communication by abnormalities of the arcuate fasciculus, the person gets conduction aphasia. Conduction because you conduct the information from this area to that area, but the conducting pathway is disrupted. So damage to the arcuate fasciculus. The person in that case will have minimal impairment in auditory comprehension because Broca's area has, Wernicke's area has all the stuff that it has. And Broca's area is intact and it has the skills it functions or the skills that it facilitates, but just sending the information back and forth. So in most cases, the person will have just slightly impaired auditory comprehension. They have good spontaneous speech because spontaneous speech is mediated by Broca's and the motor cortex for the most part. They have difficulty repeating sentences and words. They make a lot of literal paraphasias. For example, like instead of burger, someone might say durger. Bike, they might say spike. So they just change one letter or one sound and replace it with another. That's literal paraphasias as compared to verbal. Verbal is a whole word. And then the person is aware that there's a problem. So they try to make corrections. But the one who has Wernicke's, they are not aware. They just think they are totally making great sense when they do not, indeed. And then there's anomic aphasia. Anomic comes from the word name. Nom means name. So it's difficulty naming and retrieving words. They call it sometimes without a person without words, like the struggle trying to find the word to use. So that is the problem here is caused by damage to this area here between Wernicke's and the inferior parietal cortex in this little area here, in this circle here. That is where the damage will be for anomic aphasia. The person has significant word finding difficulties, difficulty retrieving names of objects, pictures, concepts, and it will make a lot of paraphasias and circumlocutions. Remember, they have severe difficulty with naming things and remembering names. So they kind of try to go around, beating around the bush. That is what circumlocutions are. So say I want to have a bottle, but I can't say bottle. So give me the thing that you drink from. give me the drinking container. So going around it, but not naming it. Paraphasias can be literal, involving single sounds, or can be verbal. Speech is fluent, means that they can produce, their motor skills are intact and they can make speech, and they have good comprehension. And then there's transcortical aphasia. Transcortical means that the pathways in the cortex, the covering, that top layer of the brain, the pathways that go across the cortex, they are abnormal. They get damaged. If these pathways get damaged in the frontal lobe, the frontal lobe is the major hub for motor execution, for motor production. And that you can imagine if there's widespread damage to the frontal lobe, then the person will have transcortical motor aphasia. That means they would have difficulty producing speech using their muscular system. Their comprehension is good, but they have difficulty starting a conversation or starting speech. If the damage affects the parietal lobe, this green area here that is engaged in the processing of sensory, of all your sensations throughout your body, if these pathways are damaged here, then that will produce transcortical sensory aphasia, because this whole area is dedicated to sensory processing. So that is the sensory aphasia. Is characterized by poor auditory comprehension and good repetition. Then there's global aphasia. From the word global, you can see that it goes into a widespread damage across the brain, and especially inside of the left hemisphere. Inside of the left hemisphere, because we said aphasias only occur in the left hemisphere. So all across the left hemisphere, there's damage, widespread damage, and all parts of language processing are severely impaired in terms of motor production, comprehension, and so you can imagine that Broca's area is affected and the circuits around it, and Wernicke's area, and the arcuate fasciculus, and a lot of areas in that affect, basically impact language fundamentals. So here is a summary of all the aphasias we discussed, and it tells you what the name is and the basic characteristics that as we discussed them. In terms of assessment, usually, speech pathologists work in the intensive care unit, and they also work in rehab and so on, and inside of the hospital. So when there's injury, immediately in the intensive care unit, the speech pathologist is one of the first people to go and do an evaluation, and they evaluate swallowing, they evaluate cognitive functions, and they evaluate language functions. So, and they also look at, of course, the whole team, they look at different body functions and activities and the level of participation. So this is a whole team assessment, and the professionals work together. In terms of intervention, just 1 minute. For assessment, there are standardized tools that can be used to give you an accurate, objective kind of measurement of the functioning of the individual. And there are also tools that the hospital has, and tools that you as a clinician develop to kind of get additional information. And then you put all of this together and you make a diagnosis of what kind of aphasia there is, and are the characteristics, and how that aphasia is affecting the person's life in terms of family, work, and so on. So for intervention, the focus is on empowering the patient to communicate successfully, to regain as much of what that patient has lost as possible. The focus here is driven by function, because most of the people who have aphasia are adults. Yes, it affects children, but the majority of these patients are adults. And you connect what the damage and the problem and the impact of it connected to their life, and you make the focus of the intervention on life goals. For example, if someone wants to go back to work and they want to know how to communicate with their peers, they want to know how to do their job, so you focus on the language skills that they use at their work. Maybe someone is more interested in saying, no, my goal is I live in a, say, nursing home. I want to know how to communicate with the people I'm living with. I want to know how to go and order a meal in a restaurant. And so you work with them on identifying the most important goals for their lives, and then you start with these, and then you go from there. So the treatment targets activation of the neural plasticity mechanisms that I explained earlier, so you can maximize the effect of the treatment and maximize the spontaneous recovery potential for that patient. There is a system of cues, hierarchy, different levels of cueing based on the easiest and the most direct, to the subtle cues, and depending on the needs of the patient initially, these cues or prompts can be using pictures, using like giving a tip, like a sound. The person's trying to recall something, say burger, and they can't. And then you might say, simply closing your lips and looking at them. They can look at, they might get the cue. If they can't, then you make it more direct. But give the sound. If they can't, then find the picture. So there's a hierarchy from the the most subtle and complex cue to the easiest. So you can enable the client to use their mind, their brain to work out and come up with the answer. There's phonological rhyming to kind of speed the processing of sounds, and compensatory strategies. Like, say someone is having a tough time to recall something and just doesn't, so, and is going to wants to go to a restaurant, or so you can say, okay, this means good, yes, you can use your thumb. This means no. This means I'm not sure. Something like that. So compensation is trying to use strategies to kind of go around, to bypass the difficulty that the person is having by using different techniques. And family support. Commonly, most of us establish groups of family, kind of make aphasia groups, and people and their families come together and they meet together either weekly or every couple of weeks, and they kind of talk and discuss and they learn from each other, and they interact, and they feel there's some kind of support for them because they have similar experiences. There are restorative and compensatory, approaches and ways to treat, and a lot of resources online, computerized systems, and also, books and kits and so on. The restorative approaches try to focus primarily on the areas that are affected, the skills that are lost or damaged, and they try to just focus all the time on repairing, the restoring that impaired language. They don't focus as much on what the person has, what the person knows. And there are also the compensatory approaches focus on facilitating different multiple ways of communication, like using gestures with sounds, with kind of some words. So kind of it's a combination based on what the patient has and is able to use. And also there are supported communication for aphasia that focus on training conversational partners and being with the person, like a volunteer, a student volunteering, or someone, a community member volunteering in a rehab hospital or in a hospital to read to the patient, to be next to the patient and give them company and discuss and tell stories and just socialize. And the idea is that the more you socialize, the more spontaneous person will regain. There are also groups, intervention and groups. When you have a group and you can put out topics and work with these with the people and also with their families as well. It gives some kind of empowerment when you have people with different experiences and they can learn. And also the social aspect of the learning process of being part of a group enhances learning generally. And this is a very powerful dynamic in a classroom. When you sit in a class and you have all these people around you physically, you are more motivated to learn. So here again are the concepts that we discussed, and we now come to the conclusion. I don't want to repeat them again. I want the video to be short and brief as much as possible, and I hope that you found it helpful and beneficial. And we conclude now.